So we start on the second part of our talk about anemia during pregnancy. So having done the iron deficiency anemia, which is the commonest one as we have mentioned, having done the anemia due to hemorrhage, then we go into megaloblastic anemia. Megaloblastic anemia developing during pregnancy almost always results from folic acid deficiency. There are other factors for it, but almost always in pregnancy is due to folic acid deficiency, usually found in women who do not consume fresh green leafy vegetables, legumes, or animal protein. Women who do not consume these are likely to have megaloblastic anemia due to folic acid deficiency. Anorexia often intensifies and further aggravates the dietary deficiency in it. Other causes of megaloblastic anemia resulting from folic acid deficiency are malabsorption syndromes that include tropical sprue, extensive jejunal resection, gastrectomy, and Crohn's disease. Sometimes hemolytic anemias, malignancies, and some antifolate drugs. These are other causes, but the commonest is dietary deficiency, not eating food constituents that contain folic acid. So megaloblastic anemia, if you look at the smear or blood film smear, it is macrocytic hypochromic anemia, most often encountered in the third trimester. Macrocytic, this is megaloblastic, and hypochromic, resulting in symptoms of anemia, the one we have mentioned early on, weight loss, anorexia, roughness of the skin, and glossitis. Severe cases may exhibit thrombocytopenia and leukopenia caused by deficiencies in folate, most common, or vitamin B12, resulting in impaired DNA synthesis with ineffective erythropoiesis. So commonly, folate deficiency or folic acid deficiency, but B12 could be incorporated in it as a cause because it leads to impaired DNA synthesis, thus ineffective erythropoiesis. Deficiencies are often dietary or due to impaired absorption, as seen in malabsorptive bariatric surgery procedures. Some surgery being done for overweight women to reduce their weight. There is possibly a problem of absorption that may lead to iron deficiency, to folic acid deficiency anemia. So megaloblastic anemia, how to diagnose it? Peripheral blood smears showing what? Hypersegmented neutrophils, oval macrocytes, and Howell Jolly bodies. Low serum folate or vitamin B12 levels, depending on what is the cause. Is it vitamin B12 or is it folate? So accordingly, you will find low level of which one is the cause. So diagnosis, serum folate, then you look at the peripheral blood smear, and that is what you would see in it. Treatment, 5 to 15 milligram of oral folic acid provided with iron and nutritious diet. So give them good diet that contains folic acid and iron, and equally give them oral folic acid. Usually after 4 to 7 days of treatment with folic acid, the reticulocyte count is higher, and leukopenia and thrombocytopenia are corrected. As we have mentioned, there may be thrombocytopenia and leukopenia. These are usually corrected within a week of starting the treatment, and also there is an increase in the reticulocyte count, showing that the bone marrow is positively responding to the treatment of the megaloblastic anemia. Vitamin B12, if it is indicated or is the cause, could be administered orally or parenterally. Orally, 1 milligram per day is enough. Parenterally, 1 milligram intramuscularly monthly, depending on cause of deficiency. So mostly we are talking about folic acid deficiency. Then we go to the third or fourth group of causes of anemia during pregnancy. That's anemia of chronic diseases, certain chronic diseases which are there before the pregnancy, they continue during the pregnancy, and they are possible causes of anemia during pregnancy unless properly managed. So these are diseases associated with chronic inflammation. They can cause mild to moderate anemia. In those with pre-existing anemia, it may worsen as the plasma volume expands. She had the chronic disease and she already had anemia before the pregnancy. Then during the pregnancy, anemia will worsen because of the disproportionate increase in the plasma volume and the red blood cell volume. Frequent causes of chronic diseases that could lead to anemia during pregnancy are chronic renal insufficiency, inflammatory bowel disease, connective tissue disorders, granulomatous infections, and malignant neoplasms. For treatment, make sure that the iron stores are adequate, and you can give recombinant erythropoietin with or without intravenous iron, whether it's indicated or not. This has been used to treat anemia stemming from chronic diseases. So obviously you do the treatment for the chronic disease itself, or you continue with the treatment of it, and then you can give them iron and recombinant erythropoietin to be given with or without iron. The other possible causes of anemia is hemoglobinopathies. Genetic abnormalities in the globin portion of the hemoglobin molecule that can either be qualitative, resulting in structural abnormalities like sickle cell anemia, or quantitative, resulting in a decreased number of normal globin chains in the thalassemia. Normal adult hemoglobin or hemoglobin A composed of 2 alpha globin chains and 2 beta globin chains. That's hemoglobin A constitute about 96 to 97 of our blood. But there are 2 types of other blood that could be present within the body. That is hemoglobin A2 and hemoglobin F. Hemoglobin A2 is about 2 to 3%. Hemoglobin F is about 1% or less. So this is the normal composition of the body. Mostly hemoglobin A, 2 alpha and 2 beta chains, but there could be 2 alpha and 2 gamma or 2 beta and 2 delta chains, leading to hemoglobin A2 and hemoglobin F. So geographically, African, Southeast Asia, and the Mediterranean are associated with the higher risk of being a hemoglobinopathy carrier. So we go to the first one, we said qualitatively, sickle cell disease. Describes a group of autosomal recessive hemoglobinopathies resulting from abnormal sickle hemoglobin that includes homozygous sickle hemoglobin, then it will be called hemoglobin SS, often called to sickle cell anemia, or sickle cell hemoglobin C. Combination of both, then it will be hemoglobin SC. And sickle cell beta thalassemia hemoglobin, hemoglobin S, then beta thalassemia. So all these could result in sickle cell problems, but the disease usually is the homozygous sickle hemoglobin SS. The hemoglobin S differs from hemoglobin A by a substitution of valine for glutamic acid in the sixth position of the globin chain. So hemoglobin A contains in the sixth position of the globin chain valine, but in hemoglobin S it is glutamic acid. That is the difference between the two. Then what happens in sickle cell disease? Sickle cell anemia or hemoglobin SS is the most common phenotype, occurring primarily among people from sub-Saharan Africa, South and Central America, Saudi Arabia, India, and Mediterranean countries. And we, the Sudan, are part of sub-Saharan Africa, where we have hemoglobin S in certain regions of our country. When the patient comes to you from there, you have to check for that. And we usually do it in most of the antenatal clinics we do. So hemoglobin S, when deoxygenated, it becomes less soluble, tends to polymerize into rigid aggregates that distort the red cell shape, make it into a sickle shape due to deoxygenation. Any condition that reduces the oxygen supply to in our blood in a sickle cell disease patient, that would lead to sickling, and these sickle cells will lead to extravascular hemolysis outside the intravascular system. The anemia usually in sickle cell disease is normocytic, normochromic. Normocytic, normochromic, with a hemoglobin concentration of 6 to 10 grams per deciliter and a hematocrit of 18 to 30. So you find the anemia, and then you look into the peripheral blood film, you may be able to see the sickle cell. Affected patient may experience hemolytic anemia, recurrent pain or vaso-occlusive crisis due to microvascular obstruction by the sickle cells. That could lead to infarction of multiple organ systems and infection due to being functionally asplenic. Spleen is there, it's not functioning. So there is recurrent pain or vaso-occlusive crisis. That's to say there is microvascular obstruction, obstructing the vessels, leading to infarction, reduction of the blood supply into multiple organs. And this will present with the clinical picture. The vaso-occlusive crisis itself could be triggered by if there is infection, if there is hypoxia for any reason, if there is acidosis, dehydration, psychological stress, and this can result in severe pain, fever, organ dysfunction, and tissue necrosis. There is the vaso-occlusive crisis resulting from these, and they can cause severe pain, fever, organ dysfunction, and tissue necrosis. Serious complication of sickle cell anemia or hemoglobin SS is acute chest syndrome, characterized by combination of respiratory symptoms with hypoxemia, non-infectious lung infiltrates, and fever. It's quite severe complication of hemoglobin SS or sickle cell anemia. Diagnosis confirmed by hemoglobin electrophoresis, typically showing that hemoglobin S is almost 80 to 95%. As we have said, normally we have hemoglobin A, 96 to 97%. Here, hemoglobin A will be absent. And there is normal hemoglobin A2. We have mentioned to say that it is 2 to 3. And there is moderately elevated hemoglobin S, which is normally about 1%. Here it could go up to 15%. So the important point here is that hemoglobin S is very much increased. Hemoglobin A is absent. That is by hemoglobin electrophoresis. The lab will tell you what sort of hemoglobin is there. Also, you'll find that the reticulocyte count is increased, and the peripheral blood film smear will show sickle cells, what we call target cells, and Howell-Jolly bodies. Jaundice may result from the destruction of the RBCs, hemolytic. That will lead to unconjugated hyperbilirubinemia. The bilirubin will be high, the unconjugated one. So these are the diagnosis of what you should do to diagnose sickle cell anemia or hemoglobin SS. Patients with sickle cell disease are at increased risk of sickling during pregnancy because of increased metabolic requirements. There is vascular stasis and also a relative hypercoagulable state of the blood in general. During pregnancy, the blood is usually hypercoagulable. So to these factors, the sickle cell, the patient is more likely to have risks and sickle cell crisis during pregnancy. An increased incidence of sickle cell crisis during pregnancy may result in episodes of severe pain, typically affecting the bones or the chest. Crisis in pregnancy may be precipitated by hypoxia, stress, infection, and hemorrhage. Pulmonary hypertension is found in almost up to 30% of the patients and is associated with a high maternal mortality. So increased risk of sickling during pregnancy due to the causes being mentioned, that will lead to increased risk of sickle cell crisis with a typical picture of severe pain affecting mainly bones or chest, and crises in pregnancy are precipitated by hypoxia, stress, infection, and hemorrhage. So obstetric complications in women with sickle cell disease include spontaneous miscarriage, intrauterine growth restriction, fetal death in utero, intrauterine fetal death, low birth weight, preeclampsia, and premature death. So spontaneous miscarriage, intrauterine growth restriction, fetal death in utero, low birth weight, preeclampsia, and premature death. These are the obstetric complications of sickle cell disease during pregnancy. Management: these patients are more prone to UTI, bacteriuria, pulmonary infections and infarction, and possibly more painful crisis in the bones and joints. So how to approach the management? Multidisciplinary approach: obstetrician, hematologist, physician. If there is need for any orthopedic surgeon, if there is any problem with the bone, then it is a multidisciplinary multidisciplinary approach. What to do? Give pneumococcal vaccine before pregnancy and folate supplementation of 1 to 4 milligram, a higher dose of folate supplementation. Give iron supplement only if the iron is deficient to avoid iron overload. Give folic acid definitely, but iron only if it is deficient. Fetal well-being should begin at 32 weeks gestation, and monthly sonography should be performed to evaluate the fetal growth. It doesn't mean that it shouldn't start before 32 weeks. No, it starts at the time of booking, as we have mentioned earlier on, at about in the end of the first trimester. Continued from there on. But from 32 weeks onwards, we look for the IUGR, intrauterine growth restriction, and hopefully not to find an IUFD. Mode of delivery dictated by usual obstetric indications. It doesn't change the mode of delivery. The mode of delivery depends on the obstetric problem. She could deliver normally. She could deliver instrumental delivery. She could have a cesarean section, depending on the obstetric indication for the type of management to be used. Management of sickle cell crisis. If crisis occurs during pregnancy, and as we mentioned in the earlier slide, what do we mean by crisis? So if crisis occurs during pregnancy, these are the management you should use, and these are taken from your textbook 10 teachers without any modification. Prompt treatment, adequate hydration, as we have said, dehydration could precipitate a crisis. Oxygen, enough oxygen, give analgesia for the pain, screen for infection, whether it's the urinary tract or the respiratory system, give the necessary antibiotics accordingly. You can give them blood transfusion depleted from leukocytes. You can do exchange transfusion in the severe cases. You give prophylaxis against thrombosis, and hypercoagulable state, and also sickling will lead to vaso-occlusive state. So give them heparin and do the fetal monitoring. So if any crisis occurs during pregnancy, this is what you should be looking for. We go into the other group of hemoglobinopathies, the thalassemias, alpha thalassemia and beta thalassemia. Encompass a group of inherited blood disorders that can cause severe microcytic hypochromic anemia. So you can see it looks like the iron deficiency anemia, microcytic hypochromic. Alpha thalassemia and beta thalassemia result from absent or decreased production of structurally normal alpha and beta globulin chains, respectively, generating an abnormal ratio of alpha to non-alpha chain. So affecting the alpha and the beta globulin chains, causing alpha thalassemia if the affected is the alpha, or beta thalassemia if the affected chain is the beta. And that leads to an abnormal ratio of the alpha to non-alpha chains. The excess chains form aggregates that lead to ineffective erythropoiesis and or hemolysis. So the aggregates lead to ineffective erythropoiesis, formation of RBCs in the bone marrow, or after being produced, there is hemolysis. Both diseases are inherited in an autosomal recessive fashion, beta thalassemia or alpha thalassemia. We tend to get it in the Mediterranean area here, Southeast Asia, and in part of the Arab world here. We don't see very often of it in our country. So diagnosis, usually microcytic and hypochromic, as I have said, with an MCV of 80 fetal per liter, similar to iron deficiency anemia, but with important differences in clinical presentation and laboratory testing. Clinical presentation, laboratory testing different, but the peripheral blood film smear more or less similar to iron deficiency anemia. So what we need to do is electrophoresis to know the type, and we do iron studies to exclude iron deficiency anemia. Molecular genetic testing should be done, and we use polymerase chain reaction is needed for the diagnosis. Peripheral blood film picture, similar to that of anemia, then do electrophoresis to see the type of the hemoglobin there at the alpha and the beta chains, and also do iron studies to exclude iron deficiency anemia, and sometimes we do molecular genetic testings by PCR. What do they do in pregnancy? Women with trait status for either thalassemia require no special care. Pregnancy may exacerbate the anemia, necessitating transfusions with an increased risk of congestive heart failure and premature delivery. Affect seriously or increase the anemia, then resulting into these problems of transfusions that may lead to congestive heart failure and premature delivery. That is the effect on pregnancy. Also, there is an increased risk of neural tube defect. That is secondary to folic acid deficiency. So give them up to 4 milligrams per day. Preconceptional folic acid supplementation is recommended. Preconception and also during pregnancy. Give them a higher dose of supplementary folic acid. We normally say the required dose for supplementary is about 400 micrograms, but here we give a bigger dose for the fear of neural tube defect. Iron supplements should be prescribed only if iron deficiency is present. Otherwise, they will lead to iron overload. Both in sickle cell disease and in thalassemias, don't prescribe iron unless there is a deficiency in it. Pregnancies may be associated with hydrops fetalis, intrauterine death, and preeclampsia, possible complications of the thalassemias. Periodic fetal sonography to assess the fetal growth in thalassemia patient is recommended. So we go to the next, thrombocytopenia. We have done the hemoglobinopathies. Thrombocytopenia, low platelets, is defined as platelet count less than 150,000 per liter, caused by increased platelet destruction or decreased platelet production. Occurs in about 10% of pregnancy, either increased destruction of the platelets or decreased production of the platelets. Clinical signs of thrombocytopenia are fatigue, easy bruising, epistaxis, gingival bleeding, and hematuria. This usually occurs when the platelet count is less than 50,000 or less. 50,000 or less, then you see these symptoms. Counts below 50,000 may also increase surgical bleeding. The risk of spontaneous bleeding increases only when the platelet count falls below 20,000. And significant bleeding may occur with a platelet count of 10,000. So thrombocytopenia leads to bleeding in different organs, easy bruising, epistaxis, gingival bleeding, hematuria during surgery because of the low platelet count. What do we mean by gestational thrombocytopenia? That is to say, It occurs only during the pregnancy. Found in 78 of the patient's population, account for 80% of cases of mild thrombocytopenia during pregnancy. This is the gestational thrombocytopenia. Diagnosed by exclusion. 4 criteria should be present for exclusion to say this is gestational thrombocytopenia. That's say occurring during the gestational period. These 4 criteria are mild thrombocytopenia, 75 to 150. No previous history of thrombocytopenia except during pregnancy. Priorly, no history of thrombocytopenia. No bleeding symptoms, and the platelet count should return to normal within 2 to 12 weeks postpartum. If these 4 criteria are present, then we can say this is gestational thrombocytopenia occurring during the pregnancy. It will resolve itself by the end of the pregnancy. In about 2 to 12 weeks, the platelet count will be normal. So we have to monitor the platelet closely to detect decreases below 50,000, because we know, as we have mentioned, below the 50,000, there are these causes of bleeding. We have to document the normal neonatal platelet count. If the platelet count is very low, treat with corticosteroids or intravenous immunoglobulin G. They could be considered. Avoid fetal blood sampling in labor and avoid instrumental delivery for the risk of fetal thrombocytopenia causing neonatal hemorrhage and hematomas. During labor, we usually monitoring it, and if we see fetal distress, we take a fetal blood sample by just making a small prick to the fetal skull, and then we assess the pH. That should not be done if you are suspecting or if there is gestational thrombocytopenia. Don't take fetal blood sample, and equally don't do instrumental delivery by forceps or ventouse. Cord blood sample must be collected to exclude neonatal thrombocytopenia. Then if it is there, it will lead to certain problems, and we have to look at it. I think this is the one before the last slide. What about hypoplastic and aplastic anemia? Very rare during pregnancy, but still have an idea about them. Major risks are hemorrhage and infection if they occur. Rates of preterm, preeclampsia, fetal growth restriction, and stillbirth are increased in cases of hypoplastic or aplastic anemia. Management: give granulocyte transfusion during infections. Red cells are transfused to improve symptomatic anemia. And platelet transfusion may be needed to control the hemorrhage. Okay, and we need the red cells, we need the platelets. And the mortality, unfortunately, is very high, up to 50% of women with hypoplastic or aplastic anemia. But as I have mentioned, it is a very rare situation. Just think about it. The more common thing you think about, preventable, is the iron deficiency anemia and anemia due to acute blood loss. Then we can go into the megaloblastic anemia, anemia from chronic diseases. Then we go to the hemoglobinopathies, which are not very rare. We do see them in our country, and you have to be aware of them and to see what you can do for them. Thank you very much. And we stop here, and this is the end of our talk about anemia during pregnancy.